Okay. Hello, everyone. Welcome to today's live broadcast. The title of this broadcast is Vitamin D Supplementation in Pregnant Women, Effects on Preeclampsia and Asthma in the Offspring. My name is Litonjua, and I will be presenting today with my colleague, Dr. Scott Weiss. We are delighted to bring you this educational web seminar presented by LabRoots. For more information, please visit labroots.com. Now, we have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can in the time allotted. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window or submit your problem through the green Q&A button on the lower left. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your web page and follow the process of obtaining your credits. I would now like to share a little background information on myself and my colleague, Dr. Weiss. As I said before, my name is Litonjua. I am a physician at the Brigham and Women's Hospital and an associate professor of medicine at Harvard Medical School. I received my medical degree from the University of the Philippines and completed a training program in internal medicine, pulmonary and critical care fellowship, and an additional research fellowship at the Brigham and Women's Hospital. I am board certified in critical care medicine and pulmonary disease. My research examines the way in which environmental exposures and genetic factors impact the development of asthma in children, and I'm currently, together with Dr. Weiss, studying the impact of vitamin D on lung disease, and am the recipient of funding from the National Institutes of Health. My co-presenter today is Dr. Scott Weiss. Scott Weiss is a professor of medicine at Harvard Medical School and the director of personalized medicine at the Partners Healthcare System. He is also co-leader of the Systems Genetics and Genomics Unit and an associate director of the Channing Division of Network Medicine at the Brigham and Women's Hospital. He co-leads a 30-investigator, 110-person research group involved in examining the environmental exposures and genetic risk factors for the development of asthma and COPD. He is the author of over 800 peer-reviewed publications and has been funded by the NIH for over 45 years. So we'll get started with a presentation. The first half of this talk, I will present our results from our vitamin D trial called the Vitamin D Supplementation in Pregnancy, or the Vitamin D Antenatal Asthma Reduction Trial, where we supplemented pregnant women to see if we could prevent asthma in the children. We all know this is the figure that we've seen in our medical textbooks and physiology textbooks, where we see, we know that vitamin D is produced on sun exposure by 7-hydrocholesterol in the skin being converted to vitamin D in the circulation. This then goes into the liver, goes through the liver, and gets hydroxylated to 25-hydroxy vitamin D, which is the major circulating metabolite. 25-hydroxy vitamin D in the circulation then gets hydroxylated in the liver to form the active hormone 1,25-dihydroxy vitamin D3. The half-life for vitamin D that we get in the sun, or cholecalciferol, is about 4 days. The half-life of 25-hydroxy vitamin D is 4 weeks, and the half-life of 1,25-dihydroxy vitamin D is about 4 hours. So you can see the differences there in terms of half-life. Now, we know that Classically, we've been taught that vitamin D works on bone formation and the skeletal system, but over the past 10 to 20 years, we now know that there are non-skeletal effects of vitamin D, and in fact, vitamin D is important for overall health and survival of the human species and a lot of animals. So in this slide, we have just a summary of some of the known effects, of the known non-skeletal effects of vitamin D. In particular, for asthma, we know that vitamin D affects the immune system, and that's what's important in asthma. So shifting gears a little bit to talk about vitamin D deficiency and insufficiency. Vitamin D insufficiency and deficiency is prevalent worldwide. It can be seen in all countries, especially countries that are transitioning to a westernized lifestyle. As humans, we evolved without any clothes and producing vitamin D from sun exposure, and as we have progressed, we have cut out that mode of vitamin D production, and we're very dependent on our intakes through food or supplements. And you see here in this review article that infants are at high risk for being vitamin D deficient, and also pregnant women and lactating women are at very high risk for developing vitamin D insufficiency and deficiency. And that's why we thought it was very important to have a clinical trial to then supplement women, pregnant women, to then see if we could affect the outcomes in the children. Vitamin D is the only nutrient that we know of where there is good data that has shown that vitamin D levels have decreased over the years. So this is a study done in the NHANES study, which is a national representative sample from the U.S. The black bars represent the proportion of the population that had sufficient vitamin D levels, or at least 30 nanograms per ml, in 1994. And the gray bars represent the proportion of subjects who then have adequate vitamin D levels in 2001 to 2004. And you all can see that there is a halving of the proportion of the population in the U.S. that have sufficient vitamin D levels. And that's why we think it's a very important nutrient to study. Let's now look at how vitamin D can impact asthma development. So a little word about asthma first. Asthma is a chronic complex disease, and by that I mean there are many environmental factors that play into it, and also many genetic factors. There's not one gene that what we call the asthma gene. There are actually many that can impact the physiology of asthma development. So asthma classically is an intermittent disease that is characterized by symptoms that come and go. The symptoms that characterize asthma are shortness of breath and wheezing. And you can see in the diagram in the top left that when you have exacerbations of asthma, your airways are constricted, and you have a lot of airway inflammation, and you have muscle hypertrophy as this goes along chronically. There are many cells and many tissues that are involved in asthma pathogenesis, and you can see in the left lower quadrant that there are many. Actually, asthma is not one disease, but a syndrome composed of multiple exposures and multiple presentations. So it may seem simple enough to think that vitamin D can prevent this, but in actuality, because vitamin D affects many tissues and many cells in the body, there's actually good data to support its use in asthma, both in asthma prevention and asthma treatment. This is a paradigm of how vitamin D can prevent asthma and allergy prevention. So with an adequate vitamin D status that starts in utero, in the womb, lung development begins at 4 weeks of gestation, and so vitamin D can affect that early on, and that could lead to improved childhood and adult lung function if you maintain vitamin D status adequately throughout life. And vitamin D also affects the development of the immune system. It is actually a balancer between the Th1 and Th2 responses, and also a modulator of the Th17 response, which are inflammatory responses in asthma. Postnatally, if you have adequate vitamin D status, it can also improve your handling of respiratory infections in early life. We now know that the data is strong that children who develop repeated respiratory infections in life are at risk for developing asthma later, and we feel there's data to support turning off the inflammation once the infection is done. And that will aid in the prevention of asthma. So we proposed our hypothesis in 2007, and after that, a number of reports in the literature increased. However, a lot of these reports were observational data. And there's a problem with observational data because a lot of the times we're estimating vitamin D status through intakes, and that is done with some imprecision. Other studies have looked at the assessment of vitamin D status through serum or plasma 25-hydroxy, which I told you earlier is the major circulating form. The problem with these studies is that they have assessed vitamin D only at one time point, and we now know that very well that vitamin D levels fluctuate both throughout the season and throughout life. And so vitamin D is widespread, and sometimes it's very hard to detect associations if most of the populations have low levels. So we thought early on to answer this question about this hypothesis that we needed supplementation trials. We were then able to conduct the VDAART trial, which is the vitamin D antenatal asthma reduction trial. This trial has a data coordinating center, which Dr. Weiss and I co-lead in the Channing Laboratory in Boston. And we recruited subjects in 3 centers, Boston Medical Center, Washington University in St. Louis, and Kaiser Permanente in San Diego. The hypothesis for this trial was whether vitamin D supplementation in mothers during pregnancy with a child at high risk for asthma and allergies can prevent the development of asthma and allergies in the offspring. We had several inclusion and exclusion criteria. Essentially, the major inclusion criteria was that we had to have a high-risk cohort. So therefore, we recruited mothers with a personal history of asthma, eczema, or allergic rhinitis, or the fathers who had a history of these allergies. Because of practical considerations, we were able to recruit, the earliest we were able to recruit was between the gestational ages of 10 and 18 weeks. And we limited the mothers to age of 18 to 39 years. We excluded smokers, and again, because of practical reasons, we only included those who were English or Spanish speakers. We had a bunch of exclusion criteria, and you can read this here. Essentially, we wanted to cut out anything that would affect the outcomes or vitamin D. What you have here next is a summary of the study design. We targeted to recruit 870 women, but we were able to actually recruit 881 women. We randomized them then to the high-dose vitamin D arm, which is 4,400 international units. That was the 4,000 international units of vitamin D, plus the 400 that they got from the prenatal vitamins. and the placebo arm wherein they were assured of getting 400 international units of vitamin D if they took their prenatal vitamins. We followed the women monthly, and we administered questionnaires, we monitored for vitamin D toxicity, and we drew blood both at baseline and at 32 to 38 weeks. And we followed them through delivery, where we obtained cord blood measures. After the delivery, we followed the infant and child every 3 months through questionnaires, and we had yearly visits for the child to measure anthropometric measures and blood draws on the child at year 1 and year 3. The next table is a summary of the baseline characteristics, and essentially just to show you that the randomization worked, that there was equal distribution of the baseline characteristics in either arm. I would like to point out that this trial had a high rate of African American recruitment, so about 44% of the participants were African American, and based on asthma epidemiology and vitamin D epidemiology, we know that these are the subjects that have a higher risk for asthma and also a higher risk for vitamin D deficiency and insufficiency. These are more of the baseline characteristics, and again, just to show you that the characteristics were equally distributed. The next slide shows that the pregnancy and infant characteristics by treatment group, and the characteristics of the infants were very similar in both arms. What we see here in the first row is that the baseline characteristics in the mothers were the baseline vitamin D levels in the mother were the same in both arms, but we saw a high increase by the third trimester in the mothers on the treatment arm, and the cord blood levels of the children who were born to mothers statistically significant higher vitamin D levels. One important aspect, I think, in the trial were that there were no serious adverse events attributed to the treatment. And so at least for these 800 women in the trial and the children who were born, we can say that the dose of vitamin D that we used here was safe, and there were no adverse events. I mentioned earlier that asthma and recurrent wheeze is a complex outcome, and we define here. It's a multi-layered definition, but we think captured the early phenotype in the children. Based on this definition, 218 or 27.1% of the 806 children developed the outcome. There were 58 children where we could not resolve the outcome, but that was equally distributed in each arm. So what we have here are the main results of the effect of treatment on the development of asthma and recurrent wheeze by age 3. So what you see is that the children born to the mothers in the treatment arm, which is the red curve, had lower incidence of asthma recurrent wheeze by age 3 than those children born to the mothers in the placebo arm. Unfortunately, the p-value did not reach significance, despite the fact that we had a relative reduction of 20% in the incidence of asthma recurrent wheeze in the children by age 3. However, if you look at the differences in rate at age 1 and age 2, we can see that there was a bigger difference at age 1 and age 2 than at age 3, suggesting that maybe the effect was stronger early on. And just to remind you about the design, we did not supplement the children postnatally, and we could see that the levels were decreasing after birth and may have affected the outcome, the results of our clinical trial. However, when we looked at a post hoc analysis where we stratified the women or the children by the third trimester level, the light blue arm is the group of children born to mothers who were in the 4,400 IU arm and who had high levels of vitamin D, suggesting that these were the women that were adherent to the treatment. They were the ones that had the lowest incidence of developing asthma and wheeze in the trial. So this suggested to us that not just the treatment, but the level was important. And later on, we now know that nutrient trials are really different from pharmacologic trials because all potential subjects for the trial have some baseline intake of the nutrient. Thus, there's really no real placebo group as compared to a pharmacologic trial, where even those in the placebo arm had baseline circulating vitamin D levels, and that also affects the response to the treatment, as you can see here from the nutrient response curve that Robert Haney published in 2014. And so your response to the increased nutrient intake will depend on which area of the curve you are on, whether you're initially deficient or initially sufficient. So when we did additional analyses of our results, we then looked at the effect of supplementation on the risk for asthma wheeze in the children stratified by initial maternal level. And that you can see when you look at the placebo group that there was no real effect of supplementation, whether they were initially high or initially low. Oops, sorry. But when we look at the children who were born to the mothers in the treatment arm, we can see that there is a big effect modification by the initial level in the mothers, where you can see that the mothers who started off initially with higher level, we're starting to discuss the limitations of our trial. I had mentioned that this was a high-risk group of participants, so there may be some lower generalizability to the general population. We may have had lower power than we anticipated. And as I mentioned earlier, that the timing and dose of supplementation may not have been optimal to fully prevent asthma and recurrent wheeze in the children. So adherence may also be an issue, and we think that maybe one dose may not fit all women, that maybe if you are coming in with a lower level, that you may need a higher dose to make up for that. And also, we did not supplement the children postnatally, and we now know that lung growth continues through adulthood, and the immune system is plastic and is exposed to a lot of environmental exposures postnatally, so we may not have captured that. In conclusion, for this part of the talk, vitamin D deficiency is widespread. I think I've shown you data for that. Pregnant and lactating women are at high risk for deficiency and may affect the risk of offspring for the disease. Our data suggests that a dose in the range of 4,000 IU per day during pregnancy is safe, and that our results are very suggestive of an effect of prenatal supplementation of vitamin D on the development of asthma and recurrent wheeze in the children. I think our results can inform future studies of the role of vitamin D in asthma and allergy, and we've learned a lot of things based on this. So with that, I think I will turn this now over to Dr. Weiss, who will talk about the effect of vitamin D on preeclampsia.
Okay, thank you, Gus. So in the VDAART study, we the initial grant did not include preeclampsia as an outcome, but we felt very strongly, based on data that was in the literature, that it was important for us to collect information on preeclampsia and then look at that as a secondary outcome in the trial. So just by way of disclosures, I'm a paid consultant to Illumina Corporation. As Gus noted, I've been funded by the NIH for 41 years, and I'm an unpaid consultant to Novartis. So this is the consort diagram for a preeclampsia. It's a little bit small and difficult to read, but as Gus actually showed you on one of the earlier slides, we had 38 preeclamptic patients in the treatment arm and 37 in the placebo arm. So there was obviously no difference in preeclampsia outcomes between the two arms, and in terms of exclusions or exclusions, they were the same, pretty much equal between the two arms of the study. I'm sorry, so the numbers here on this slide are slightly different from the numbers shown in the consort diagram, because the consort diagram included women that may have been labeled as preeclampsia but didn't meet the American College of Obstetrics and Gynecology definition of preeclampsia. So these numbers here are slightly smaller. We ended up with a total of 67 ACOG confirmed cases, 33 in the treatment group compared to 34 in the placebo group, and that was clearly not significant. But within the treatment and the placebo control groups, there was a trend toward decreasing occurrence of preeclampsia that was observed among the women who had a sufficient vitamin D status at entry into the trial. And that was statistically significant, particularly for the early, both early and late, but particularly for those women who had a high level at both time points. So the pooled estimate of the odds ratio in the intent to treat population was significant when you stratified by these levels. This slide shows the multivariate analysis. First the univariate, then the second column is the multivariate, showing the effects and if you of the various covariates, and again adjusting for these covariates, a significant effect of vitamin D on treatment outcomes. When we model this probability of preeclampsia as a function of the vitamin D level, so it's probability of disease on the x-axis and vitamin D level on the y-axis, you can see that we had no cases of preeclampsia that occurred above a level of 38 nanograms per ml, suggesting that the risk was minimal at that level. But as you can see from this curve with the red or pink confidence intervals, the confidence intervals are much wider for these higher levels because we had fewer subjects at that point in the trial. So there does seem to be a dose-response effect. It seems to level off at a level of 38, but the number of subjects over 38 is relatively small. So the conclusions from this part of the trial is that the intent to treat analysis was not significant. It didn't show anything. But then when we stratified by level of vitamin D, both at entry into the trial and at the 32 to 38 weeks at the end of pregnancy, we found that women whose vitamin D levels were greater than 30 nanograms per ml had a decreased occurrence of preeclampsia when it was adjusted for covariates such as age, race, center, treatment arm, and body mass index. And at the minimal risk was at a level of 38 nanograms per ml. But we went on to do some genomics on these subjects, and the genomics is described on this particular slide. We took blood from the women at entry into the trial at 10 to 18 weeks of pregnancy, on average about 14 weeks, and we used the rank prod technique to identify genes that were overexpressed in peripheral blood related to vitamin D, which is on the left-hand side, and genes that were related to preeclampsia on the right-hand slide. And then we looked at the overlap of those two sets of genes, and we found 1,323 transcripts that both had a relationship to vitamin D, either up or down regulation of vitamin D, and up or down regulated with regard to preeclampsia. And then we took that gene set and tested it in a replication population, where we then came up with a smaller number of genes that were not just associated with vitamin D and preeclampsia, but were also replicated in a second population. And so that represents the 348 genes that are listed in that bottom box on this slide. We then did pathway enrichment and looked for molecular interactions using this set of genes, where we used mapped the gene expression onto the protein-protein interaction network using HumanNet, and looked for tissue specificity by looking at GTEx and other gene expression data sets. And we were able to find that 52% of the genes of our 348 genes were actually also expressed in the placenta, and that 86% of our genes could be mapped onto this molecular interaction network, or this particular, what we are calling the pre-eclampsia module. So we went on to construct something called the largest connected component of our module, where we were able to find a set of genes that was connected one to the other, that was a subset of this 348 larger group, and that module is depicted here. So the outer circle in the lighter colors is the 348. The inner circle in the red circles and diamonds are the largest connected component of this gene expression module. And on the right-hand side, we list the pathways that were most significantly associated with being a member of this largest connected component. And as you can see, immune function it was amongst the highest groupings in terms of pathways that was identified in this module. We then subsequently found that both the vitamin D pathway and the IL-10 pathway could be completely subsumed by and connected to this largest connected component. And that's shown on this next slide, where the vitamin D pathway is in blue and the IL-10 pathway is in yellow within the largest connected component. So in conclusion, for the genomic section of this analysis, we identified a gene signature based on RNA in peripheral blood of women at 10 to 18 weeks of pregnancy that predicted the occurrence of preeclampsia subsequently in the pregnancy. We also found that both the vitamin D pathway and the IL-10 pathway were embedded in this largest connected component, and that the largest connected component was enriched for a variety of immune pathways that one would think would be related to preeclampsia. So another analysis that we did linking asthma in the mother during pregnancy to preeclampsia also strengthens, and vitamin D also strengthens these connections. So we looked at both physician-diagnosed asthma in the mother and how many months of uncontrolled asthma that mother had, and whether the serum vitamin D level was related to that uncontrolled asthma. And in the multivariate model on the right-hand side, the next to the last and the last column, you can see that uncontrolled asthma episodes were associated with preeclampsia, and that the serum vitamin D was also related to preeclampsia when one controlled for those uncontrolled asthma episodes. So if you look at, again, the probability of preeclampsia as a function of uncontrolled asthma in the mother, you can see that there's this increase in risk, so that the greater the number of uncontrolled months of asthma the mother had, the higher the risk of preeclampsia in the mother during the pregnancy. And that this was also related to vitamin D, that again, the probability of preeclampsia shown on the x-axis and the vitamin D level on the y-axis, and this is adjusted for those asthma control months, shows the similar relationship to what we saw before, and that you see an additional decrease of preeclampsia risk by an average of 7% for a 10-unit increase in the early pregnancy vitamin D level. So uncontrolled asthma in the mother was associated with preeclampsia risk. The vitamin D level was linked to both the uncontrolled asthma in the mother and the preeclampsia risk, and vitamin D levels was the connecting link between both uncontrolled asthma in the mother and preeclampsia risk in the mother. To our knowledge, this is the first time that there's been a link between the vitamin D and uncontrolled asthma and preeclampsia in the mother, and this, coupled with the gene expression that occurs and antedates before the occurrence of preeclampsia, strongly suggests that vitamin D is a critical factor in the development of both preeclampsia and asthma control status in the mother. Finally, I'd just like to acknowledge all of the people that worked on these projects, particularly Human Mirzakhani, who's the fellow who did these analyses, and our group of obstetricians and gynecologists who helped us with the reviewing of the charts and the asthma diagnoses, as well as my colleague, Dr. Litonjua, and Dr. Sharma, who performed the network analyses that I just showed you. So
great. So I think the next part of the presentation will be the question and answer period. So before we get started on that, I'd like to remind our audience on how to submit the questions. We already have some here, but for those who haven't submitted, you can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. And we'll try to answer as many questions as we can. So looking at the questions here, the first question is, does vitamin D supplementation in pregnancy decrease the risk of having a low birth weight infant? So do you want to answer that, Scott?
Yeah, so the question is, what is the effect of vitamin D during pregnancy on birth weight? We're in the process of doing an analysis of that in our cohort. It's not been completed yet. It does appear as if there are some effects of vitamin D on birth weight, but we haven't completed the analysis yet, and so it's probably premature to get into too much detail about that. I will also say that we did look at preterm birth, and that was on one of Gus's slides. We did see more preterm birth in the placebo arm of the trial, but it was not statistically significant. If you took out the preeclampsia cases, the number of preterm births was very small. It was only a total of 18. So we had relatively limited power to look at that outcome as well.
Yeah, so to answer that, you would need a much bigger trial, which we weren't powered for. The next question is, how could ovulation affect asthma? And I'm not sure, I mean, in terms of the parent and child, I don't think there is any relationship that I know of. Within the same person, for example, if a female has asthma, would ovulation affect asthma status? I don't think I'm not aware of any data there also. But I think in terms of the monthly cycle, I think there are, menstrual cycle, there is epidemiologic data that the menstrual cycle can affect asthma, where there could be a worsening of asthma symptoms during the menstrual cycle. But other than that, I'm not aware of any studies for that.
And there is evidence, some from the Nurses' Health Study, but some from other studies as well, that asthma in older women is definitely related to exogenous estrogen use. So hormones, both progestins and estrogen, can influence asthma control in women, but I think that Gus is right. With regard to ovulation per se, we're unaware of any data on that particularly.
Right. The next question is, can single supplementation vitamin D and combination calcium supplement and vitamin D be better? So I think the question is asking whether vitamin D versus vitamin D and calcium can better reduce the risk of preeclampsia and eclampsia than calcium supplementation in pregnancy. And we didn't test that in our trial, but and I'm not aware of any other trial that has looked at that question either.
Yeah, I think that if you go back to the issue of vitamin D, calcium, and asthma, there's clearly no evidence that the effects of vitamin D are mediated by calcium on asthma. So for the asthma vitamin D relationship, I think we can say pretty conclusively that this is absolutely has nothing to do with calcium. It's occurring at levels that are above and beyond what you would need for a normal calcium metabolism related to bones. As far as the preeclampsia relationship, we're not we didn't test that, and we're not haven't really reviewed the literature on that. So we'd have to think about that a little bit more.
So there was a question on asking to explain the role of vitamin D in asthma, and I had a slide that I had presented earlier, and I brought it up, and hopefully you can see that, where vitamin D has many effects on many tissues in the body. So it has effects on the Th1, Th2 pathways that you're aware are active in asthma, where it seems to control the switching from a Th1 to Th2, from a Th2 to a more Th1 response. It also has effects on modulating the Th17 response, which is a pro-inflammatory response in asthma. Vitamin D has been shown to have effects on lung growth and development, and it has effects on the mass of the smooth muscle in the airways. So if you have adequate vitamin D and you have asthma, you're at lower risk of developing smooth muscle hypertrophy, and then you don't have as bad bronchoconstriction. And I also talked about earlier the effect of vitamin D on infections. I think the data seems to show that vitamin D will not prevent viral infections. What it does is many of us can have an inflammatory state after we have viral infections. The virus is gone, but somehow our immune system is still revved up. And there are experimental data that has shown that vitamin D can turn off that exuberant inflammatory response. And I don't know if you want to add anything more to that.
No, I think the simple way to think about it is that there's two groups of effects. One are structural effects on the developing lung. The others are effects on the immune system. The structural effects in the lung, there's more data for alveolarization in animal models, but we have shown that the effects occur very, very early in lung development at the time of branching morphogenesis. So it's really airway size, smooth muscle size, and lung maturation. And then, as Gus said, these immune effects, which I think in the broadest sense is really vitamin D functions as a rheostat in an electrical analogy for the immune system, sort of damping down the unwanted noise from antigens that the immune system doesn't really want to respond to, and giving greater control to the T regulatory cells over the inflammatory response. So I think it's basically those two effects that are critical. And we think that it's generalizable beyond asthma to other autoimmune diseases. We think that the effects may be slightly different in preeclampsia, but clearly immune-mediated predominantly there, where there may be a role for vitamin D actually in implantation in the wall of the uterus.
So the next question is a question about how to rectify vitamin D deficiency in a 20 to 25-year-old person who may be born with vitamin D deficiency. And again, here, I think it would be actually vitamin D supplementation. And I would recommend measuring the levels when you start supplementation and to follow up maybe every month for the first few months. And if you find that the patient is very deficient, you would obviously give higher doses on the order of 8 to 10,000 international units per day, and then you bring that down to about 2,000 to 4,000, depending on the levels that you achieve. And the data currently is that I think you want to have a level of at least 30. Our study suggests that maybe even a level of 38 to 40 may be optimal, and maybe even higher than that. But I think you're on the safe side to say that at least 30 to 35 would be a good target.
Yeah, I think that the 2 points that Gus emphasized, one is it's important to know what the starting level is. Because if somebody's very deficient, then you're not going to be able to rectify that with just minor degrees of supplementation. So measuring the level initially, and then recognizing that it is a fat-soluble vitamin, so body mass index plays a role here, and particularly as you become more, body mass index goes up, and this is a particular problem in the United States, the fat reserves serve as a sink and they will suck out vitamin D from the serum or plasma. The other final point here, which I think is a critical one, is that we tend to use serum vitamin D level as the biomarker for sufficiency, but it's not really the level in the peripheral blood that's the index of sufficiency. It's really what's in the tissues, because all of these immune cells have the ability to locally make the 125 active form of the vitamin if they're provided with enough 25 OHD to do that, and that relationship, which is 1-to-1 in a lean person at sufficient levels, becomes dissociated as the BMI goes up and the level goes down.
So we have a little less than 10 minutes, so let's try to, we have 4 more questions, so I think we'll be able to finish this. The next question is, asthma incidence is high in areas of high trafficking with high car exhaust and air pollution. Was environment statistically accounted for in the asthma studies? We did not look at it here in our trial, but there is data out there where they've looked at a cohort of children and calculated the distance from a major roadway, which is a good proxy for the amount of exposure to car exhaust and air pollution. And they found that the children who had higher vitamin D levels, even if they lived closer to a major roadway, had decreased wheezing and asthma symptoms than if they had lower levels. So we think vitamin D also has, or we know vitamin D also has antioxidant properties, which can abrogate some of the effects of air pollution, at least in children and at least in their symptoms. We still have to, more studies need to look at this more carefully. And then the next question is, some persons say that asthma is genetically related, and I'm going to let Dr. Weiss answer this. Based on the ability of vitamin D to prevent asthma in offspring, can this claim be refuted?
So that's an excellent question. I think that one of the things that we're starting to look at in the VDAART trial now that we have some genetic and genomic data is what is the relationship between the principal asthma locus in children, which is the 17q locus, which transduces the effects of environmental exposures such as respiratory illness and smoking in terms of the asthma risk. And while it's still early, it does appear that there is a relationship between vitamin D status and this locus. But if you have the risk allele, that risk is still an independent risk factor, independent of the vitamin D, even though there may be some relationship between these two things. Asthma risk is genetically is not conferred just by this locus. HLA is also a very important locus. There are probably 50 genes or 70 genes that have been identified by a variety of genetic association studies that may be important in asthma. And it's still too early to say exactly how the vitamin D finding relates to these genetic results.
Thanks. So the next question is calcium supplementation alone better than vitamin D supplementation alone in improving asthmatic patients? And I think it's been already shown that calcium is not a treatment for asthma. And in fact, if you want to go back to the studies that they did back in the 1930s, where they supplemented vitamin D, and the thinking there was that calcium probably had a role, and they were trying to drive up calcium levels in asthmatics using vitamin D, but they did not see an effect of calcium levels. In fact, it was the effect of the vitamin D supplementation that alleviated the asthma symptoms in those patients. So I think, again, we don't think calcium per se has a role in asthma treatment, but we think vitamin D can help both in the prevention and in the treatment of asthma patients. Anything more to say? And then I think we have one last question. And it says here, did you assess for any associations of baby birth date or season and vitamin D levels in the asthma part of the study to help answer any concerns for confounding by seasonal changes in vitamin D? So that's an excellent question. As I mentioned earlier, and as we know, vitamin D levels fluctuate during the season. We actually used the dose of 4,000 international units of vitamin D per day because a previous study by Dr. Hollis and Dr. Wagner showed that that was the dose that took away any seasonal fluctuations. So when we look at our data, there's no seasonal fluctuation in vitamin D levels in those who were born, or in the children who were born in the treatment arm. And so we were able to abrogate the effect of season on asthma development using vitamin D. But that was a very good question.
But we also, again, in addition to that, we also monitored UV light exposure and have skin monitors and pill counts in addition to the vitamin D levels to ensure that we have both an accurate assessment of how much sun exposure the children and the mothers had, as well as being able to look at the effect of that sun exposure in the mother and its effect on her levels. So we have a lot of information both on seasonality and on sun exposure from these sun monitors that we can potentially use in other analyses. But there was no seasonal variation in the mothers, as Gus points out, at least in the treatment arm.
Great. So I think that was the last question. I'd like to thank once again LabRoots for the chance to present. Do you have any final comments? Okay. So I think there are no further questions. We'd like to thank again all the participants and for sending in your great questions. Just a reminder that today's webcast will be available for on-demand viewing through February 2017. You will receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event, and we hope to see you at another webcast. Thank you very much.